Hello, and welcome to today's webinar, Precise and Dynamic Value-Based Care. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Mr. Shatang Patel, Dr. Mitch Kaminsky, and Ms. Amy Burke. Shatang Patel is the AVP of Health Plans and Consulting at Citius Tech. His expertise spans healthcare management and health policymaking with a focus on payer strategy, business operations, and supporting technologies. He holds a master's degree in health services administration from the University of Michigan. Dr. Kaminsky is a family physician who has combined clinical practice and teaching with a career in healthcare leadership that has included private groups, hospital systems, and academic institutions. Since joining the Jefferson College of Population Health as associate professor in August 2018, Dr. Kaminsky has led enhancement of the college curriculum to include greater emphasis on value-based care, population health management, and an increasing focus on the social determinants of health. Amy Burke is the Director of Population Health for Microsoft. She's an accomplished, results-oriented healthcare executive with successful completion of diverse, complex projects in both the provider and payer sectors and on an extensive global level. At this time, I would like to turn the floor over to the speakers. Sorry, Amy, I think you're on mute.
Sorry for that. Good morning, and thank you for having me here today. It's a pleasure to be with everybody. Value-based care is really at a tipping point. It's been around since, 2000s, and with the validation of Obamacare, hence the ACA legislation, it really set itself in motion. And today we're at a point where we see the intersection of value, engagement, empowerment, and outcomes. What does value-based care mean? And, Dr. Kaminsky is going to answer that in a moment, but value-based care at its core is really around improving the lives of patients, members, consumers even, right, throughout the care continuum across various care settings, and harnessing quality. How is it that we can achieve on quality outcomes and be reimbursed for that quality so we can demonstrate that we've actually made a difference? I would just say too that it really empowers the consumer. The consumer, is around empowering themselves to take better care of themselves, to take responsibility of their health outcomes, is a large part of value-based care. Shared decision-making with their providers, comes to mind in terms of how we can really achieve those improved health outcomes. And finally, just a note around social determinants of health and health equity, and we're going to talk about this more too, but the notion that value-based care is moving away from the brick and mortar setting. It's going into home care and into the community environments. And we see partnerships with community-based organizations to address on social determinants of health, to address behavioral health, and to really then achieve health equity and reduce health disparities overall. So with that said then, I'm going to ask Dr. Kaminsky some poignant questions here. And thank you for being with us today, Dr. Kaminsky. It's really a pleasure. So, when we think about value-based care, how is it that you define value-based care?
Well, thank you, Amy, and thank you for the introduction, and particularly thank you to everybody who logged in this morning to hear more about our perspectives on value-based care. I work with Amy, so it's especially fun for me to participate in this webinar. I think the simplest definition for value in value-based care is that value represents either the quality or outcomes or both of the care that we provide divided by the cost. So value-based care takes into account not just clinical outcomes, but also financial outcomes. It's driven by an unsustainable rise in healthcare in this country that is really driven by a fee-for-service model, which rewards primarily volume of services. Value-based care, in order to reduce costs, would like to reduce waste. And about a quarter of waste is due to unnecessary tests and procedures, and another quarter is caused by administrative complexity. The fee-for-service model, which is still our dominant model, does nothing about that waste in healthcare, whereas value-based care has to. It is essential that we look at reducing waste while we're improving outcomes and improving value.
Thank you. And bringing up that financial piece is so important, right? Holding providers accountable for the outcomes in which they're achieving and reducing on redundancies, as you said, and really being reimbursed accordingly based on quality outcomes, I think is the key takeaway. As we think about, the CMS alternative payment models, the APMs, if you will, the value-based care models that are out there in the industry today, they've been around for some time, as I mentioned. How effective have these models been, and where do you think that these models are leaning towards in the future?
Sure, happy to answer that. So CMS really took the lead in promoting value in healthcare and trying to address rising costs. Uh, the Affordable Care Act, which is now 11 years old, really allowed CMS to develop ACOs, or accountable care organizations, and many of the alternative payment models, alternative to fee-for-service, which they've developed to promote value-based care. It's an opportune time, and in fact, the government and industry leaders have taken this 10-year anniversary that we just passed to really look back over the 10 years and answer the question, how effective have these models been? And what we found, what they've reported on, is that if you're looking at the net cost of care, in other words, how much money we spend for healthcare, and include the quality rewards, the financial rewards to successful organizations that do well in the alternative payment models, very few of these models have actually resulted in a net reduction in care. Now, there's a lot of debate about that because we're trying to estimate reducing costs of care when costs are continually rising. So it's a much more complicated question. A couple of things that we do know is that if an organization, a healthcare organization, embarks on a value-based care trajectory, the longer that they do it, the more successful they are. We also know that when we tie financial risk to the alternative payment models, in other words, there is a budget determined, often historical, and if an organization doesn't achieve budgetary goals, they risk having to pay back some of the money as well. All of these models are including quality, and I like to say that quality improvement is necessary but not sufficient in order to achieve value-based care. But quality is an important component because if it was simply about reducing the cost of care, we could neglect care or deny care and impact quality adversely if we didn't consider it.
Very interesting. So, Dr. Kaminsky, please then, present on the CMS framework for the next decade. I think it's very interesting, and I'll let you take this slide, as we think
Sure.
about where value-based care is going.
Yes, so this was actually a diagram in an article in Health Affairs in December of 2020. And as I mentioned, it's an opportune time to look back over the past 10 years and to look forward over the next 10 years. CMS developed this framework, which is very high level and basic, but I think it will help all of us to better understand where we're going. And what is remarkable about this framework at the top is that there is a move toward population-based models. And that's another term for models that are looking at both the cost and quality of care for a population. And there are two main components. One major component on the upper right is the primary care provider. So primary care practices are at the base of accountable care organizations and are seen as integral to achieve value-based care. There have been advanced primary care models promoted over the past 10 to 20 years so that primary care practices are better able to manage the demands of providing quality care, chronic and preventative care, while also addressing costs. The other major component on the left are the acute care and specialty care. And what you see in this diagram is whereas primary care is responsible for coordination of care, the acute care facilities, hospital, outpatient surgical centers, and specialists are engaged in value-based care through transparency and competition. And there are bundled payment models that look at chronic condition episodes, those considered inappropriate for admission if outpatient care was appropriate for conditions like diabetes, but also acute medical episodes, specific diagnoses and procedures where the hospitals and specialists work together to reduce the total cost of care over a 90-day episode for that acute medical episode and the surgical episodes such as major joint replacement. Hospice is increasingly being considered in these value-based payment models because often that is a much more appropriate venue of care than futile care in an ICU.
Wonderful. And if I could just ask one more question before we move on to the next slide. What about the notion, as I mentioned, that value-based care is moving into the community? How is it that value-based care is going to take hold of community partnerships and social determinants? Can you touch upon that, please?
Yep, and we will talk more about that when we talk about barriers. But when we look at barriers, and I'll talk about a few of them, one of them is that there is very uneven success in medical care across this country, and it is driven by health disparities. So even though wealthy areas may have really good quality metrics and manage costs better, in poor areas, if you don't consider those social determinants of health or social drivers of health, you end up failing to reduce the total cost of care. And I think we'll talk about that a little bit more in a few slides.
Most definitely. Thank you. We actually have a question from Marty Camardi of Microsoft. Given 25% of waste is recognized in the complexity of administrating value-based models, where do you see opportunities to simplify the model that you just highlighted?
So there are attempts, but I think it's very difficult when you consider the number of commercial payers and all the administrative staff that they have and all of the administrative procedures that are required to care for patients. So there is talk about standardizing referral requests, standardizing denials. So there's a lot of work, but again, it's challenging because there are so many different players that it's hard to deal with that administratively. The CMS programs have much, much lower administrative costs than commercial payers because they are large and they are one system.
Most definitely. Thank you. Shatang, I'm going to hand it over to you, so please.
Sure, and Amy, I want to carry your question forward. First of all, thanks again to the audience for joining and very happy to be part of this awesome panel. So you mentioned some of the models going into the community. What other models do you see in the industry outside of what has been kind of pushed by CMS, especially in the private sector?
Well, Shatang, CMS is often the leader in new models of care and the commercial payers follow. So I think that to varying degrees is happening. You see a lot of commercial payers adopting some of the same quality metrics and some of the efficiency or cost metrics Although, again, they're rooted primarily in fee-for-service, so it's a very uneven uptake. One other value-based model that is worth mentioning is the partnership of commercial payers with Medicare in the Medicare Advantage programs. There are clear financial incentives to reduce the total cost of care, and those partnerships are doing that through value-based models that truly look at complicated patients and provide more services for them to avoid the costly acute care that is frequently what they experience.
Absolutely, and we see this quite a bit, especially in the MA world, where they certainly seem to be farther ahead in terms of really figuring out which incentives work to truly meet your definition that you outlined, which was quality plus outcomes divided by the cost. And I want to kind of talk about that a little bit, because what you measure when you think about that definition is extremely important, and that measurement varies across all these different types of models that are there, and even some of the innovative ones that are coming up. In your view, how should outcomes be measured within these value-based care arrangements that exist today?
Yes, well, I think it's imperative that we look at total cost of care. We just have to do that because of the challenge to our country in reducing our escalation of costs. So I think that the outcomes have to always include total cost of care. Quality, as I mentioned, is necessary because without monitoring and improving quality, costs of care can be reduced simply by denying care or providing lower quality care. I think those need to be the main focus in outcomes. Again, we'll talk more about social determinants of health, and we're seeing increasingly that outcomes in those social determinants are increasingly going to be important in order to address healthcare disparities.
Absolutely. I think we have seen a lot of movement already to include member-reported or patient-reported outcomes, right, to truly measure their quality of life and the impact on their quality of life as a result of this. So I think that measurement is going to become even more tricky because a lot of times this needs to be longitudinal in nature, and surveys come into play. So truly executing that becomes a little bit more challenging, but we'll talk about some of those challenges a little bit more. I want to go back to the study that CMS did in terms of the effectiveness. Considering the ROI garnered to date, what are the key barriers? And I know you alluded to social determinants of health, but can you talk a little bit more about the key barriers to advancing value-based care, especially in the context of getting that higher ROI from all the investments and efforts that we have put into this?
Sure. I think that one of the key barriers is if fee-for-service continues to be our dominant payment model, and estimates are that it represents about 90% of payment. Providers, insurers are not going to invest so much in value-based care when they have to keep a foot in two boats, the fee-for-service boat and the value-based care boat. When we reach that tipping point, and we are approaching a tipping point where more of the payment models are based on value principles and fee-for-service is less dominant, then I think the current payment system, the fee-for-service, will be less of a barrier. A second key barrier is, as you saw, the models all depend on primary care to serve as the source of coordination of care, addressing the total cost of care. And in our country, we invest in primary care 1/3 of the amount that other advanced countries invest in primary care. So I think a real barrier is our shortage of primary care, our lack of investment in primary care, and that has only gotten worse over the past 10 years. And then finally, a key barrier to advancement, as I mentioned, are the disparities in care, which have to be addressed in order for us to have a reduction in our total cost of care across this country.
Yeah, let's emphasize that a little bit more, and I'm going to push us forward to the next slide. And just to level set, and Dr. Kaminsky, I'll let you take this, but we just want to level set with the audience. Social determinants of health. I understand everybody already knows what social determinants of health are, but just wanted to level set and talk a little bit more about how they are truly a barrier and how to think about value-based care along with social determinants of health.
Sure, Shatang. So this slide summarizes a lot, the definition of social determinants of health. And I advocate for calling it social drivers of health as well. Determinants suggests that it's not changeable. Drivers, I think we can change. The World Health Organization defines social determinants of health as the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. And there are many different categories of social determinants of health. These 12 categories that are promoted by the Institute of Medicine, I think summarize 12 of the social determinants of health very well. That includes employment and working conditions, education and literacy, childhood experiences, income, physical environment, social supports and coping skills, healthy behaviors, access to health services, biologic and genetic endowment, gender, culture, and racism. And we know that 10 of these are modifiable, and these are what drive the disparities that keep us from achieving a healthier population. Amy, I don't know if you want to add anything, because I know you teach this as well. And you're on mute, Amy.
Sorry. Thank you. I think it's really important when we think about social drivers of health, as you quoted. It's transportation, it's about food insecurity, et cetera. And I'd be remiss if I didn't say, working for Microsoft, we think a lot about the digital divide, right? Those that can access technology. We are in a world of technology today. We're digitizing, innovating with technology, but yet many of our members don't have access to technology, right? So how can we cross over the digital divide? Health literacy comes to mind as well, very important as we think about social drivers of health. If I'm of a different culture, a different language, et cetera, how am I to understand what I'm being presented with in terms of my healthcare, right? That becomes very important as well. So I just wanted to touch upon those two scenarios, if you will, and think about then how we can solve for them in the broader industry. I think that's really important. I'm going to move on to the next slide because
Amy,
when we think about value, yeah,
sorry, Amy. I just want to interject some examples. When the pandemic hit in primary care and we were converting patients to telemedicine, something I had never thought about is that in order to have a telemedicine visit, you had to have an email address. And I never thought that patients may not have email addresses. And so we had our medical assistants teaching some of our patients how to develop an email address. And then the other thing a telemedicine visit required was a ability to pay for the visit through a credit card or a bank account. And there again, many of our poor patients didn't have bank accounts or credit cards that they could use to pay for a telemedicine visit.
Yeah, no, most definitely. And in my experience, when I was the director of care management for our duals populations, we were engaging in virtual visits for conducting assessments and care plans. And many of our population didn't really understand how to even use computers, right? So there's a lot to really overcome as we think about and implementing technologies, and we have to think about our members, our populations, our patients, if you will, as we assert on innovation in technology. I just want to say that. But when we think about value-based care, it's related to advancing health equity. And, COVID has very much surfaced the inequities in this country, inequities amongst race, gender, and so forth. And, how is it then that we link quality and equity together. It's very important that we do so. And CMS is starting to take into account social drivers of health as we think about CMS star measures, as we think about risk adjustment. For reimbursement, et cetera. So health equity is not going anywhere anytime soon, and we have to address it. We have to reduce the disparities, not only from a moral perspective, right, because everybody in this country is entitled to equitable healthcare, but also from the notion that value-based care is about reducing total cost of care, right? So first and foremost, we have to understand and address social determinants of health and disparities. So what can the data tell us, right? Data is power. Data informs us of what we need to know is how we reach out to our patients and our members, how we intervene with our patients and member populations, and then how we evaluate and how we then make performance improvement opportunities. How is it that we can then leverage payment reform to reduce disparities? And the CMS ACO REACH model points to this as an example, right? A new innovative model, as in the right bottom lower quadrant there, the ACO REACH model is really thinking about how is it that we can really project on community-based organizations into the landscape of value-based care and reimburse for social outcomes, right? And then thinking about how we all up transform systems to address disparities. So it's going to take a village, right? And how we think about the payer and the provider relationships, partnerships, community-based partnerships is going to be very inherent as we advance health equity. And I like this quote, and I read this in a journal just the other day, The Road Ahead. It's a person-centric approach to healthcare. We have to tailor healthcare to the person level, to the individual level, and not focus on calling them a consumer, a member, a patient, but they are a person, and take into account their needs, their wants, and meet them where they are to advance on health equity. I don't know if anybody else has any thoughts, Dr. Kaminsky or Shatang, but please chime in.
I love the diagram showing equity. Some of the diagrams you'll see also show equality. I think it's common to think that everyone should get the same thing, you know, the services, but then you don't help everyone achieve the wellness that they can achieve. And so we are adopting equity. We realize that some patients need things that other patients don't. So if you have a patient who lacks transportation and can't afford it, should you do something to help them get to the office or to access medical care? Is just one example of how you have to think about your goal of wellness for everybody and how the disparities require different strategies for different groups of patients.
Definitely, yeah.
Yeah.
All right, go ahead, Shatang.
Yeah, no, one thing I would add, going back to the digital divide, right? It's not just about folks that have digital access or use digital access, but it's also about how those digital interactions work. From a physician standpoint, are you delivering enough empathy in those interactions to truly impact the outcome and make it a positive outcome? So even within the digital world, I think there's a huge variance in terms of how we deliver high quality health outcomes. And I think that's also something we need to consider. And we'll talk about those propensities a little bit more as we talk about the path forward. But just wanted to add that comment.
No, that's great. And actually, CMS is now under review for proposing digital intervention measures as we think about star ratings and so forth. So that, you know, with all this innovation and technology, we have to hold accountable to those that provide it. And that's very interesting. So more to come on that when we learn more about it from CMS. But Dr. Kaminsky, we have a question from the audience. Ms. Barbara Kevish of UPMC. Do you feel social drivers of health should be risk adjusted as CMS is proposing that they are?
I think that's already taking place, and I think absolutely. So we will risk adjust population based on, you know, cardiovascular measures, different chronic diseases. There are some studies that suggest risk adjusting by social determinants are actually more predictive of cost and risk adjusting by individual medical conditions. So absolutely, I think we have to do that.
Thank you. All right, I'm going to hand it back to Shatang for our next question, which is actually a poll. So, Shatang.
Yep, and this is a very simple poll. We just wanted to get a gauge of the audience members and their organizations. What percentage of your membership population today is in some form of value-based care? And this is across all product lines that you may have within your organization. We'll give you a minute to respond.
We got a lot of
I'm
them,
looking at the
Shatang?
answers. We have a few. Let's give them another 20 seconds.
Okay.
So yeah, I mean, I can react to it a little bit. So it's almost 60% up until this point is at about 25% of membership in terms of overall coverage through value-based arrangements and value-based care. I do want to mention 75% and above, it's about 42% at the moment, or actually 45% now at the moment. So, which is a little bit surprising to me because I was definitely expecting, if not majority, a far higher majority, if you will, to be at 50% or below. But it's refreshing to see that people are getting closer to 75%, 80%, 100% in terms of their journey within value-based care. Let's get back to the slides, and we'll continue to work on this theme. So one of the reasons why we wanted to get this understanding from the audience is to really talk about, so what are some of the foundational elements? As you notice from the basic poll that we did, there's a huge variance. Everybody's in different parts of their journey, right? Some at 25%, some at 50%, some at 75%, and at least one organization at 100%, which is excellent. But we just wanted to talk through what are some of those foundational elements, regardless of where you're in your journey, that you can mature over time, especially as you think about that ROI that needs to be garnered, right? Dr. Kaminsky already spoke to how some of the ROI, the measurements have not been as promising as or as high as promised, but there are ways to think through that. So the way we have set this up is there are three basic elements to this framework. Common definition of value. That definition of value is extremely important, and getting an agreement on that. Member obviously is a huge component of this, and when we say member, it's again against whole health, right? We talked about social determinants, and really the person actually is what, as Amy put it, is what's important to think about, and all the different propensities, right, across that personality of the given person, and understanding that, a complete understanding of that is extremely important. And similarly for providers, the complete historical performance, and not only in context of their particular specialty or primary care, but also in context of their propensities, right? I referenced earlier, how do they deliver empathy within a digital setting versus a personal setting? Those are very different things, and those still need to be at a very high level for improved or higher health outcomes. So just to get in a little bit more detail about each of these elements, and I'll quickly go through this. So basically from left to right, you see the higher ROI realized as you mature from left to right. So common definition of value, first and foremost, internally in your organization, right? I'm assuming most of our audience are from health insurance companies or payers. Having enterprise buy-in is extremely important across business, across IT, across data and analytics, and also from top all the way to the bottom, right? From the CEO down to customer service reps. This buy-in on what is the definition of value and how that needs to be incorporated within day-to-day operations becomes extremely important. The next level of maturity is having that same common understanding with your partners, providers, communities, state agencies, and making sure that those common definitions are documented appropriately, contractually, however you want to frame them, but then you're moving forward together as partners rather than in two different directions or with two different set of understandings. And finally, you really need to collect as much information and data as possible to inform those definitions and to make sure that those definitions, those common definitions, are true to what they were intended to be. So interoperability obviously comes into play. And in the member layer, you see, obviously it starts with a longitudinal record. Again, against whole health, all aspects of the person needs to be incorporated in that longitudinal record. Then once you segment that population and that membership, then creating those clinical pathways. And this becomes a little tricky because you want to standardize them to a degree, but at the same time, they need to be individualized as well. So it's a very tricky balance, and we'll talk about that a little bit more in the path forward. And then finally, focusing on structured data. At the end of the day, as Amy pointed out, data is power. And having structured data just gives us easier means to disseminate that data and get it into the hands of the right people for decision making. So focusing on structured data becomes extremely important. On the provider layer, optimizing your network and reimbursement, right? Using machine learning to do that becomes extremely important. Again, something that folks are already starting to do pretty well. Exploring innovative models. Amy referenced the ACO REACH model. There are a lot of models that are already coming into play with employers, providers, community-based organizations, state agencies, as we mentioned. So exploring more innovative ways to create value and deliver those healthy health outcomes is extremely important. And obviously, this requires, if you want to do this very well, it requires bi-directional exchange with all those partners. And having the supporting technology infrastructure, architecture to really have bidirectional exchange to get to as real time as possible, as close to real time as possible, becomes very important. So what you see on the very right column is the highest level of maturity, and you see data interoperability are a big component of that. So that leads me to our next question, Dr. Kamensky. I want to pick your brain a little bit more. What role can interoperability play when it comes to addressing some of those barriers and challenges that you discussed earlier?
Well, I think interoperability is essential in order to succeed in value-based care. I just don't think you can do it without interoperability. We can't transform our healthcare system unless we capture data, analyze it without the firewalls or barriers that exist. Usable data, whether for clinical or financial purposes, requires interoperability. Now, there are organizations where healthcare providers and insurance providers are breaking down the barriers to sharing data, most often in payviders. These are large organizations that include not only the management aspects, the financial management aspects, but also the healthcare aspects. And so we hear a lot about payviders, and that certainly will promote interoperability to be able to share data across those two sectors. Chatang, we had a question come up also from Marty. So the first question was easy, and then Marty goes further and makes it a little bit more challenging. We talked about how with all these different fee-for-service payers, how complex and how much administrative waste there is. Well, to be honest, the new value-based payment models have been a real challenge for practices and healthcare systems that participate with CMS in these models. Uh, Although you could argue that there's just one payer that they have to learn the rules for and get the data from and report back, but there is definitely complexity to the value-based payment models as well. And there's continual effort to reduce that amount of complexity um, all the way from the front, from the provider, physician, nurse practitioner, PA, and in terms of what they have to document and how they document to referral processes. So I think the same kind of work is going on in value-based models to take that burdensome administrative requirement that the models require and learn it and streamline it to be less burdensome. Really good question, Marty. Good insight.
Um, so, pardon me, the path forward, Shatang, you want to talk about the path forward?
Absolutely. And we're going to do this. We're going to talk about the path forward here across these four dimensions. But there's also an illustration coming up, which I think will put this in context. But the way we view value-based care is truly a transition to personalized care. And I think you already heard the theme, right? It's about the person, it's about the personality, and it's really about that individual that you want to get to. So, it, and let me just walk through these four dimensions, and it'll sink in a little bit more. So first aspect is risk sharing, and again today a lot of this happens not just in terms of quality bonuses and just basic reporting, but also shared savings, right? Different aspects of payment based on performance across various metrics that cover both health outcomes, quality, as well as a total cost of care and components therein. But ultimately, as you move, it's going to evolve into heavy capitation or population-based payments as we get into more personalized care. So that's one dimension around risk sharing. The second dimension is measurement characteristics, right? What you measure. Again, in the fee-for-service world and in the value-based care world today, it's predefined clinical and quality targets. There's more and more moving targets now that are not just clinical in nature, but also financial in nature, operational KPIs that are utilized within these value-based contracts today. But ultimately, these are now going to become more variable targets that are specifically tied to disease progression of that given individual, and also risk against whole health, not just clinical risk. So as you see, you're starting to see how this is starting to play out, right? Ultimately getting to personalized care in terms of how the orchestration mechanism. Today there's a lot of manual components around contract definition, around cohort selection, around the definition of cohort for that matter, and certainly attribution, right? In the PCP world, it's a little bit more straightforward, but it becomes much more complicated outside of that. And there's various different methodologies used today, even for attribution. This is becoming a little bit better and a little bit more precise in terms of getting actionable information at the point of care in the value-based care world. But ultimately, this is where technology and certainly machine learning can play a significant role, not only determining the targets in terms of the how, but also managing the incentives in terms of the how. So technology and advanced analytics in particular will be a significant part of that personalized care as we move into the future. And then finally, data exchange. We can't talk enough about data. None of this is possible without data and utilizing that data for decision-making purposes. And I would just say that we're starting to see some real-time visibility today, but it's still more near real-time, right? It's not gotten to truly bi-directional, even though there's some regulations that are going to push this forward a little bit more. We're still only starting to see bits and pieces of it. But ultimately, in the personalized care world, you're going to have a truly interconnected and coordinated ecosystem which incorporates all aspects of the healthcare industry, from payers, providers, digital therapeutics, as we mentioned, communities, state agencies. I think a truly connected system is what is going to lead to some of the improvements that we're looking for from personalized care delivery as into the future. I think just to make this a little bit more real, we have an illustration specifically focused on diabetes and how technology can play a role, especially modernized technology. Amy, if you can cover that, that'd be fantastic.
Unmute, Amy.
Amy, you're
Still on mute. My gosh, I apologize. But
your
really,
best friend.
this illustration this illustration is depicting a diabetes program management using technology, and technology is the wave of today and tomorrow and the next day as we think about value-based care to optimize on these models. And I go back to the care management workflow, if you will, because care management is the heart and soul of value-based care. I'm going to say it again. It's those care managers that are working hard out there to manage members to get them to their best selves in terms of their health, right? Holistically health, clinical, social, and behavioral health outcomes is what they're all trying to achieve for. So embracing technology and engaging with providers is the way in which we can really promote for that better health outcome. And the way in which we do that is we identify members. We identify and risk stratify members. So we can identify those members that we can have the most impact on with the targeted interventions in which we comprise and deliver on. Data informs us of our members, right? So we know our members with the data. And having that data in one unified view of whole person health only makes it, shall I say, easier, more informed for better decision making, etc. Defining the program then, right? How is it that we can define the interventions more targeted? Being able then to define the quality metrics and align those quality metrics to reimbursement and configure those reimbursement models appropriately. And this is where artificial intelligence can play a part, as Shatang had noted before. Enrolling then members, so giving the opportunity to automate on enrollment activities, being able to automate on engagement, outreach and engagement, pardon me, being able to use data in a way that will enhance the way in which we engage with our members throughout their care journey is also very valuable as we think about technology and value-based care. And then the way in which we engage providers. Providers are essential as we think about value-based care. They are the ones that are delivering the treatment. They are closing those gaps in those gaps in care each and every single day. And we have to have vehicles for communication, for collaboration, and for data exchange, interoperability, and other type of communication collaboration tools. And then how we monitor on outcomes. So data is being harnessed to intervene, but data is also being harnessed to evaluate on the outcomes. What insights have we learned of our individual patients, but also at a population level? And how is it then that and might I say too, how we monitor our providers against the quality outcomes that they need to be achieving? So, you know, this is an illustration of how technology can really optimize the value-based care environment. And might I even add then on the interoperability piece, right, to exchange data where it needs to be exchanged and exchanging it in the most real time for real-time decision making at the point of care, and being able to then align on quality measures to reimbursement again. So I will just stop there and see if there are any questions from the audience before we move to our final survey. So we have another question for everybody. The poll, Shatang, if you don't mind, because you have control of the poll.
Absolutely. And so I know this question is toward the end, but it's on purpose. But based on everything you have heard and your own experiences, right, with your own organization, how effective is value-based care, or do you think value-based care is effective? Is it truly achieving what is intended to do in terms of improved health outcomes based on the models you have implemented thus far, or the arrangements that you have set forth thus far? So simple question, yes, no, or unsure in terms of overall effectiveness of value-based care.
And we didn't give you a choice of yes and no.
All right. So yeah, it seems like majority seem to think that it is effective. It's close to 70%, but there's a lot. There's almost 25% in the not sure bucket, which obviously is exactly what we were after here, right? And there's also less than 10% that are in the no bucket. So 2/3 yes, 1/3 unsure or no is where we're at in the poll, Amy and Dr. Kaminsky.
Thank you. And Dr. Kaminsky, for those that are not sure, how can we make them sure? What is going to happen to move the needle, so to speak, or what has to happen to move the needle?
Just as CMS did a retrospective for 10 years and found that net savings were rare, I think we need to continue to measure the success of these value-based care models. I think if you said you're not sure, it's a legitimate response. I think we're all looking for more data. We're all working hard now to capture and address social determinants of health. But it's so new that we don't have a lot of outcome measures to show that all of this work that we're putting into place and that is built into the ACO REACH model, in fact, is going to show us an ROI that we're looking for. So for the not sure people, I think that's um, a reasonable response. And I would say keep reading about it. And I will too. And I'll be looking for more evidence these coming years in the success of these value-based payment models. I know that there are many pilots that CMS runs, scores of them actually, and outcomes are continually measured with those. But it takes time. It takes 5 years of a pilot model and a lot of analysis to really understand what it is achieving.
Thank you. And our last question, Shatang.
And you're on mute, Shatang.
It's contagious. Unless the answer was 100% yes in the previous poll, this wouldn't matter because we feel trust between payers and providers is really lacking to truly execute value-based care, right? So, Dr. Kaminsky, from your perspective, uh, uh, will payers and providers ever trust each other to form those meaningful partnerships that can actually deliver on the promise of value-based care?
So I think when they have common goals, then trust is natural. And so we're starting to see that in our payviders, in the Medicare Advantage programs, where the payers and the providers are working together to manage the total cost of care. I think fee for service keeps a gulf between payers and providers because it's strictly volume based and it's all about the numbers. But when you add in the outcomes of care and how our patients are doing and what we're achieving in our population, once we have these payer and provider groups working together, then trust naturally follows.
And we actually have a question from the audience, Ms. Michelle Middleman-Horner from Cigna. While data is key, how do you prevent analysis paralysis and move to action? That's a great question because there's so much data out there. And, I have my own thoughts on this, Dr. Kaminsky, but please go ahead and comment.
So I lived it with a CEO who was a clinical provider, but was a real numbers geek and really into data. And I think you need that kind of clinical leadership in organizations to drive the analyses, to prioritize the different initiatives. So I think top clinical leadership is really critical to prevent the analysis paralysis that a lot of us experience.
Yeah, and I also would say too, having a strong data governance model in place as well. To your point, to prioritize data and really understanding how to use that data amongst your team becomes very important. The operationalization of the data, to your point, Michelle, about moving data to action. So that's going to be very important as we go forward. And I think we have to start teaching data and analytics earlier in programs as we think about educating our providers that are out there in the universe, right? Our nurses and physicians, to educate them on data and analytics in nursing schools and medical schools, because data is now how we deliver on care and it should be part of curriculums. That's just my immediate thought on that. But all right, so great discussion today. So what can we do to really then take the next steps around call to action on value-based care? I was always taught, when we think about change management, because value-based care is a change, right? It's a change from fee-for-service to outcomes, quality outcomes, accountable outcomes. It's people, process, and technology. So, as we think about calling to action for what's next and what you as your what your organizations can do, Examine and comply to value-based care regulations. CMS.gov, healthit.gov, great resources. They are always putting policy in place around value-based care, updating policy, changing policy, etc., and redefining on policy around value-based care. Creating provider and community-based partnerships, including the business agreements that need to be in place. It's very challenging to have partnerships anyway, but putting those business agreements in place, creating those partnerships and might I say relationships is ever so important, especially as we move towards social drivers of health, as we have talked about during this discussion. From an infrastructure perspective, being able to stand up people, process, quality metrics, and technology to optimize on a value-based care environment, getting buy-in from your leaders, or excuse me, from your resources at your organization, and leading with clinical leadership. To Dr. Kaminsky's point, those clinical leaders become champions, right? And they're involved in every step of the way as you move towards a value-based care environment. Planning for ongoing process improvement to optimize on the value-based care outcomes in which you want to achieve. And as you stand up your infrastructure, taking a step back, securing funding sources. There are many grants out there. CMMI, which is the Center for Medicare and Medicaid Innovation, often has pioneer projects and looking for pilots with organizations out there in the ecosystem. And partner with vendors like Citius Tech, like Microsoft, where we can accelerate on your goals around value-based care. So with that, we thank you for your time today. It's really been a pleasure to talk about this very important topic, and one that is priority in the healthcare landscape today. We wish you all a very happy holiday season, and thanks again for your participation.
Amy, there's a question about whether the presentation will be recorded and shared.
I believe that is the case, yes. So we can certainly check with AHIP, but I do believe it is being recorded and that it will be shared for public domain.
To our speakers,
that's
thank you for
affirmative.
that great, to our speakers, thank you for that great presentation and for sharing your thoughts. And thank you to the audience for participating in today's webinar. And yes, that webinar will be available within 1 to 2 business days. This concludes today's presentation. Thank you again and enjoy the rest of your day.
Thank you.